We have 5 more conditions in addition to the tumors: acute pancreatitis, chronic pancreatitis, autoimmune pancreatitis, pseudocyst, and nesidioblastosis. Acute pancreatitis, nobody excises it or nobody biopsy it. Most of the time we see it in the autopsies. These pancreas are from autopsies. It shows extensive necrosis, and microscopically you see the saponification. The pancreatic enzymes, they come out and they auto digest the adjacent structures and produces soap formation with the calcification with the extensive necrosis and neutrophilic infiltration. Chronic pancreatitis is very, very important because the chronic pancreatitis, sometimes it may look like tumor, and microscopically also it may look like tumor. We have to be careful. This lobular pattern in the low power is very, 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 very important to diagnose chronic pancreatitis. If you go individual cells, they may look malignant, but this lobular pattern is very, very important. What happens in chronic atrophic pancreatitis? A lot of the acini and the duct system undergo atrophy, whereas the endocrine component may be present as nests or individual cells in a sclerotic stroma. That's where it looks like malignancy. Here you see, even here it is seen around the neural bundle. So we may think this is carcinoma. But when you do the neuroendocrine marker synaptophasin, all these cells are positive for neuroendocrine tumors. So chronic pancreatitis is a greatest mimicker of carcinoma, grossly as well as microscopically. So you have to be very, very careful. Autoimmune pancreatitis, there are two types, type 1 and type 2. Type 1 is known as IgG4 disease, where serum IgG4 elevated, and you see three characteristic features: lymphoplasmacytic infiltration, storiform fibrosis or lamellar fibrosis, and obliterative phlebitis. These three triad is very, very important for type 1 acute pancreatitis, whereas type 2 acute pancreatitis, we call it gel, granulocytic epithelial lesion. I will show you the picture. Both are responsible to steroid, okay, 100% responsibility. And this type 1 autoimmune disease can involve other organs, and type 2 autoimmune disease usually associated with inflammatory bowel disease. So grossly it may look like a tumor, but microscopically it's lymphoplasmacytic infiltrate, storiform sclerosis, and phlebitis. This is the triad you have to remember. See here, it can be ductocentric and lobulocentric. And microscopically, you see around the ducts lot of plasma cells and lymphocytes, and see a major artery. And in here, there's a vein that shows inflammation and obliteration. So this is a phlebitis. And microscopically, you can see the lamellar fibrosis. And see, this is the artery. Sometimes in the H&E, it's difficult to identify the phlebitis. So elastic tissue stain may highlight the phlebitis component. And when you do IgG4, it will be more than 50%. Type 2 autoimmune disease, it's again ductocentric, and it shows lot of neutrophils that are going into the epithelium. That's why it is known as granulocytic epithelial lesion, gel. Remember any gel you use, okay? Gel is type 2. Coming to pseudocyst, again, nobody biopsies or excise the pancreas. Most of them are autopsy findings. This is a cystic space with extensive necrosis, and it won't show any definitive lining epithelium. Again, it will look like acute pancreatitis, fat necrosis, and saponification. Nesidioblastosis is a condition where there is a ductocentric neuroendocrine cell proliferation. Here in this high power, you can see very nicely a duct, and the neuroendocrine cells are proliferating around the duct. This usually happens in infants of the diabetic mothers. The insulin from the mother stimulates, the lack of insulin stimulates the neuroendocrine cells in the babies. Nesidioblastosis. And when you do synaptophasin, you can identify the increased number of neuroendocrine cells. Now we are coming to immunohistochemistry in pancreas. These are the 7 conditions where immunohistochemistry will be helpful. I told chronic pancreatitis and the ductal carcinoma can be very, very difficult to identify. And in those cases, VHL, MASPIN, S100P, and IMP3 will be very, very helpful. For pancreatic neuroendocrine tumors, chromogranin, synaptophysin, PGR, and Paxate. But insulinoma associated protein, INSM1, I think Kundavai's thesis is on that. That is the new marker that is excellently positive in neuroendocrine tumor of any organ. So that's one of the new markers you have to get, and it is a nuclear positivity. So it's very, very easy to interpret. Acinar cell carcinoma, trypsin, glypican 3, and BCL10. To differentiate IPMN from mucinous cystic neoplasm, stromal estrogen and progesterone receptors. To differentiate solid pseudopapillary tumor from others, we have to do CD10, beta catenin, nuclear and cytoplasmic positivity, and PGR. For plasmablastoma, trypsin, beta catenin, and synaptophysin. For serous adenoma versus others, I remember I told you serous adenoma associated with one hyperlindo. So PVHL and MUC6 will be positive, and inhibin A will be positive. For completion's sake, I am putting this table, various types of mucin stains, but to me, they are not very, very useful. But in the exams, they may ask you. The only important thing I see here is in ITPN, the MUC5AC, MUC5 is negative, whereas it is positive in all the other types. For adenoid cystic carcinoma, it is trypsin, BCL10, and glypican 3. For IPMN versus MCN, ovarian type of stroma that are positive for ER and PR. For SPN, we already saw this picture, beta catenin, normal membranous expression, abnormal cytoplasmic and nuclear expression, positive for progesterone receptor and CD10 in solid pseudopapillary tumor. For pancreatoblastoma, it's a multilineage. All the markers will be positive. Cytokeratin, trypsin, chromogranin, alpha-fetoprotein. And the squamous nests are very characteristic. You have to remember in pancreaticoblastoma. For serous cystadenoma, it is a VHL gene, and MUC6 can also be positive. To frozen section in pancreas, only 4 things they want to know. Is there a lesion in the pancreas or in the tissue submitted for us? Is it benign or malignant? If it is a resection, is the tumor present in the margin? And if it is a lymph node, is there any metastasis? These are all the answers they want from us, and you can freely communicate with the clinicians. What do they want to know? For example, margins, in addition to tumor, they are interested in low-grade dysplasia. For example, it can be a carcinoma associated with PANIN or IPMN, and that IPMN at the resection margin may show low-grade dysplasia or high-grade dysplasia. But when you say it is high-grade dysplasia or carcinoma at the margin, they will go for further resection. And you have to remember the major and minor criteria for pancreatic carcinoma to apply strictly in frozen section. Nuclear size variation, incomplete glandular lumen, disorganized duct distribution, no lobular pattern, very, very important. That's a major criteria. Minor criteria are huge irregular epithelial nucleoli, necrosis, glandular mitosis, glands unaccompanied by stroma in the smooth muscle fascicles, and perineural invasion. Crossing of pathology, it can be a Whipple's resection, or it can be tail of the pancreas with the spleen. And this is the easiest specimen. Just take one resection margin from the cut surgical end. And many people ask me, what is resection margin? Wherever knife has been placed to cut from the body, it is the resection margin. So this is the only resection margin here. Whereas these are known as radial margins. They are floating in the retroperitoneum. Surgeon never uses knife to separate the upper and lower portions of pancreas. Once they cut the pancreas and free the spleen, it comes out as the specimen. So this is the only resection margin. And you may ask me, what happens if the tumor is there in the radial margin? You just tell in the report tumor is present in the radial margin. The possibility of going into retroperitoneum and peritoneal cavity is high when it is in the radial margin. But when it is in the resection margin, definitely tumor is there in the patient. Coming to Whipple resection, many people think it's difficult, but it is very, very easy. It has a C-shaped intestinal portion that can be proximally pylorus of the stomach or the duodenum. So this will be the proximal margin, and this will be the distal duodenum or early portions of jejunum. So proximal margin, distal margin. Then you have to identify the common bile duct. This common bile duct is another resection margin. And then you trace the common bile duct into the pancreas, and most of the tumors are around the common bile duct. And this is the resection margin of the main pancreatic mass. And this is for the Asner process, because big blood vessels, they come in this area. Okay. So the surgeons has to use the blade to release it from the bigger blood vessel. So this is one of the margins. So there are proximal margin number 1, distal margin number 2, common bile duct number 3, primary pancreatic body number 4, and uncinate process number 5. There are 5 resection margins. And then you describe the tumor, take the tumor along with the duodenum, along with the ampulla, and along with the adjacent pancreas, and look for lymph nodes. And when you see lymph nodes, you group them. For example, this is a superior pancreatic, this is inferior pancreatic. Like that, you have to classify the lymph nodes. Cytology of pancreatic lesion, it's a very big topic, but the terminologies used are non-diagnostic, negative, atypical, suspicious, positive, and then neoplastic. These are all the terminologies used. And what are the criteria? Again, major criteria: overlapping nuclei, irregular nuclear contour, chromatin clearing or clumping. You have to see either 2 or more major, or 1 major and 3 minor criteria. And the minor criteria are single epithelial cells, necrosis, mitosis, and nuclear enlargement. Please remember this for cytology. What are all the things you have to mention in the final report? You always follow the CAP protocol. CAP has 2 protocols, one for exocrine pancreas and the other one for the endocrine pancreas. In a nutshell, you have to mention tumor site and size, histological type and grade, microscopic tumor extension, margins, lymphovascular space invasion, perineural invasion, and PTNM staging. If there are any additional findings, you have to mention. If you have done any ancillary studies, you have to mention. Many patients may undergo neoadjuvant chemotherapy before surgery. In those cases, you have to mention the post-treatment effect. Molecular events, it's very, very important to understand the molecular events in pancreas. So we have to divide them into solid tumors and cystic tumors. KRAS mutation, CDKN2, P16 inactivation, TP53, and SMAT4 inactivation. These are all the 4 major changes that are seen in the predominantly in the solid pancreatic carcinomas, and they have both diagnostic, prognostic, and theranostic, where for example, KRAS mutation can have potential therapeutic target. So these molecule changes are very, very important for targeted therapy or tailored therapy. Coming to the cystic tumors, IPMN, I told you KRAS and GNAS. GNAS is very, very important. Mucinous tumors, KRAS and RNF43. Serous cystic neoplasm, as I told you, von Hippel-Lindau. Solitary pseudopapillary neoplasm, beta-catenin. So these are all the classic molecular changes. Again, they dictate the prognosis, theranosis, and sometimes they may help in the diagnosis also. For example, pancreatic cystic fluid, if it is GNAS positive, it is diagnostic of IPM. That brings the end of our discussion. The key points you have to remember: the histology of solid neoplasms and cystic neoplasms, pancreatic neuroendocrine tumor, salt and pepper chromatin pattern, the solid pseudopapillary tumor, coffee bean grooving, and hyaline globules, Asner cell carcinoma, prominent nucleoli, pancreaticoblastoma, very early age group, multilineage, and squamoidness. Coming to the key features in cystic neoplasms: pseudocyst, no lining epithelium; mucinous cystic neoplasm, mucinous lining epithelium with ovarian stroma; IPMN connected with the duct, and it's again mucinous with gastric, intestinal, or pancreatic biliary type, and this is the only cystic neoplasm connected with the duct. Serous cystadenoma, clear cells, and complexes, and VHLG. And grossly, you have the characteristic picture. Once you see the serous cystadenoma, you don't need any ancillary studies. So these are my references. See, most of the pictures are by Atul Singh. He is now in University of Pittsburgh, but previously he was in John Hopkins. I think he played a major role in the app. John Hopkins has 10 apps, including Pancreas. So you have to get all of them. Unfortunately, they are available only for the iPad, okay, not for the Android users. So please get, I think each one of them cost you 100 rupees. So they have beautiful pictures. So you have to get all the 10 apps in the iPad from the John Hopkins. Just go to App Store, put John Hopkins pathology, and you can locate these 10 apps. Manual of Surgical Pathology by Susan Lester. This is the Bible for you for grossing and how to do reporting and how to solve issues in anatomic pathology. And WHO Blue Book, CAP protocol, and very importantly, pathologyoutlines.com. So these are all my references.